Usually when we talk about a medical diagnosis,
Hmm.
there's this underlying expectation of mechanical precision.
Right, like a clear-cut problem and solution.
Exactly. You break your arm, the x-ray shows a jagged white line, the doctor points to it, and, well, you fix it. It's binary, it's clean.
Yeah, but oncology isn't really like that.
No, not at all.
Hmm.
Because the moment you step into the world of surviving cancer, that pristine diagnostic machinery basically breaks down.
It does.
You enter this landscape for you that is profoundly murky, where the cure itself leaves a physiological aftermath that, well, that nobody really prepares you for.
And that aftermath is exactly what we're tackling today.
Yes, it is. We're looking at a massive stack of medical guidelines, oncology textbooks, and FDA warnings today for our deep dive to explore that exact aftermath.
Specifically regarding surviving gynecological or breast cancer.
Right. We're looking at severe genitourinary syndrome of menopause, intense tissue damage, and patients desperately seeking relief through localized hormones or cutting-edge vaginal lasers.
Which is a whole controversial world of its own.
Oh, absolutely.
Hmm.
And floating above all of this is a critical, central question we have to answer for you today.
The big one.
Should oncology clearance be obtained before seeking any of these treatments? Okay, let's unpack this.
Well, the short answer to that is an emphatic yes.
Just a flat yes.
A flat yes, but the biological reasons behind that yes they are incredibly complex.
Right.
We are in an era where modern oncology is curing more pelvic and breast cancers than ever before, which, is a monumental scientific triumph.
It's amazing. But there's a flip side.
Exactly. That triumph has created an entirely new demographic of long-term survivors who are living with debilitating localized pain.
Yeah.
And the immediate medical challenge we face now is ensuring that the fixes patients seek for their post-cancer symptoms don't trigger a cascade of irreversible catastrophic harm.
Because before we can even evaluate whether someone should be, taking hormones or getting laser therapy, we have to look at the mechanics of the damage itself.
Right, the root cause.
We're dealing with the collateral damage of the cure. And for something like cervical cancer, radiotherapy is, well, it's the absolute cornerstone of that cure.
It is the primary tool. The current gold standard involves a combination of external beam radiotherapy.
Or EBRT.
Yes, EBRT, which is delivered to the whole pelvic region. And that's followed up by 3D image-guided brachytherapy.
Okay, and what does the brachytherapy actually do?
Well, it allows oncologists to use MRI guidance to basically sculpt the radiation dose directly to the topography of the tumor.
Wow.
Yeah, it achieves astronomical success rates. We're talking 90 to 95% local control.
That is incredible. But knowing that radiation inherently destroys cellular DNA, even with that sophisticated MRI sculpting, you can't entirely avoid the surrounding microenvironment.
You really can. There's always going to be some scatter.
Right. And the sources highlight that oocytes, your egg cells, are extraordinarily sensitive to radiation.
Highly sensitive.
So if you're delivering a curative dose to the pelvis, you're almost guaranteed to trigger immediate ovarian failure.
Yeah, the hormonal crash is immediate. It literally plunges the patient into premature menopause overnight.
Just overnight. That's brutal.
It is, but the mechanical damage to the surrounding tissue is equally severe.
Because of the radiation dose itself.
Right. When the radiation dose reaches around 45 gray, or GI, the data shows that 45 to 50% of patients develop vaginal stenosis.
Half of the patients.
Almost half. The localized tissue undergoes aggressive fibrosis, which is heavy scarring, and a massive reduction in vascularity.
So the blood flow just drops.
Plummets, yes.
That makes me think of like a high-stakes hostage rescue.
Okay, how so?
Like the SWAT team goes in and saves the building, which is the priority, right? You want to get the hostage out. You want to kill the cancer.
Right, of course.
But in the process, the walls are scorched, the foundation is cracked, and the plumbing is completely wrecked.
That is a remarkably accurate analogy.
You survived, but the structural integrity of the tissue you're left with is deeply, deeply compromised.
If we connect this to the bigger picture, the sheer success of those life-saving hostage rescues has left us with millions of women suffering from severe genitourinary syndrome of menopause.
Or GSM.
Right. They are cancer-free, but they are living with intense dryness, atrophy, and pain due to these anatomical changes.
It's a daily struggle for them.
Finding a safe remedy for GSM in this specific population isn't just a a luxury quality of life issue.
Right, it's an urgent, daily medical imperative.
Exactly.
But knowing that radiation permanently alters the tissue's blood supply creates a massive paradox when we look at how modern medicine usually treats GSM.
The hormone issue.
Yes, the hormone issue, because for the general population, the gold standard is estrogen, right? Hormone replacement therapy,
HRT. Yes.
which introduces a terrifying dilemma for a cancer survivor. Like, how do you safely take hormones to heal your tissue if you've just spent the last year fighting a disease that, in many cases, literally feeds on hormones?
It's a very valid fear. But the clinical guidelines from organizations like the British Gynecological Cancer Society provide a remarkably nuanced roadmap for this.
Oh, really? So it's not just a blanket ban?
Not at all. For cancers that are fundamentally not hormone-driven, like most cervical, vaginal, or vulval cancers, HRT is actually not contraindicated.
Wait, even if it's right in the reproductive tract?
Yes. Even though some cervical adenocarcinomas might express estrogen receptors, long-term studies simply haven't demonstrated that HRT increases the risk of recurrence for these patients.
That is fascinating. Okay, but what about for endometrial cancer?
Well, that's where it becomes highly individualized.
With a case-by-case basis.
Exactly. The multidisciplinary team has to evaluate the specific receptor status of the tumor, the stage, and the grade before making a call.
Okay, but wait. I'm looking at the data for breast cancer survivors in our stack of sources, and systemic HRT is routinely listed as an absolute contraindication.
Yes, systemic is definitely off the table.
So if you survive a high-risk hormone-driven breast cancer, and you are suffering from severe GSM, are you just, like, entirely locked out of hormonal relief?
No, and the distinction between systemic and localized treatment is crucial here.
Okay.
What's fascinating here is how effectively the body can isolate certain localized therapies.
What do you mean by isolate?
Well, while systemic HRT, where estrogen circulates through the entire bloodstream via a patch or a pill, is strictly contraindicated, vaginal estrogens administered as a cream, a tablet, or a ring are considered safe for the vast majority of these survivors.
I want to dig into the mechanism of that because it sounds counterintuitive.
It does, yeah.
How does the body keep a locally applied hormone from eventually, seeping into the systemic bloodstream?
It all comes down to cellular regeneration.
Okay, walk me through that.
When a patient first applies localized vaginal estrogen to severely atrophic tissue, there actually is a tiny temporary spike in systemic absorption.
Because the tissue is basically paper thin from the atrophy.
Exactly. The tissue barrier is so thin and damaged, but as that local estrogen begins to stimulate healing, the vaginal epithelium regenerates and cornifies.
Cortivice, meaning it toughens up.
Right. It physically thickens and builds up a robust, healthy cellular barrier.
Oh, wow.
And once that cornification occurs, the hormone is essentially trapped in the local tissue where it's needed.
So it can't cross over to the bloodstream anymore.
Exactly. The systemic estrogen levels drop dramatically and remain well below standard postmenopausal levels.
So the body effectively seals the vault once the internal walls are repaired.
That's a great way to put it. It gets what it needs locally without flooding the systemic circulation.
That is brilliant.
But
But is that safe for everyone?
Well, with one major caveat. Extreme caution is still mandated for breast cancer patients who are actively taking aromatase inhibitors.
Because those drugs do what exactly?
Those specific drugs are designed to suppress circulating estrogen to practically zero.
Oh, I see.
So even that initial tiny spike before cornification happens, that is fiercely debated in the oncology community.
Because even a tiny spike could theoretically be risky.
Right. But for most others, localized estrogen is a highly effective lifeline.
Still, even with that clear physiological mechanism, there is an intense psychological hurdle.
Understandably so.
I mean, many patients, and frankly, many oncologists, remain deeply hesitant to introduce any hormones back into the equation.
The fear is very real.
And nature abhors a vacuum. So that widespread hesitation opened the floodgates for a high-tech, completely non-hormonal alternative.
The lasers.
Yes, energy-based devices or vaginal lasers.
The proliferation of these devices over the last decade has been staggering.
It really has. I see them marketed everywhere now.
To understand the friction between the clinical reality and the regulatory bodies, we really have to look at the physics of how they operate.
Okay, let's get into the physics.
The dominant technologies are ablative lasers, primarily carbon dioxide or erbium-YAG lasers.
Right, and ablative fundamentally means destructive. I mean, you are intentionally causing damage to the tissue.
You are, but highly controlled damage.
Okay.
These lasers penetrate the subepithelial connective tissue and heat it precisely to about 40 to 42 degrees Celsius.
So they basically cook it, just a little bit.
Just enough. That specific temperature threshold causes microscopic thermal injury.
And why do we want thermal injury?
The mechanism here relies entirely on the body's natural wound healing cascade. The thermal shock triggers fibroblasts to initiate neocollagenesis.
Which is the creation of new collagen.
Exactly. Along with elastin production and angiogenesis, which is the formation of new blood vessels.
So it's exactly the same principle as aerating a lawn.
I like that. How so?
You punch deliberate, calculated holes into the compacted dirt to force a biological response, and then that grows healthy new grass.
That's exactly what's happening on a cellular level.
And the early clinical trials reflected that exact outcome, right?
They did. Patients were reporting remarkable, rapid relief from GSM symptoms. The tissue was visibly remodeling itself.
But then something changed.
The landscape shifted violently in July 2018.
Right, when the FDA stepped in.
Yeah, the FDA issued a stark public warning against the use of these energy-based devices.
The FDA commissioner came out swinging.
It really did.
They warned that these devices were being aggressively marketed for, quote, vaginal rejuvenation.
Which is a terrible term medically.
Yeah, and they cited severe risks like burns, scarring, and intractable chronic pain.
And it wasn't just the FDA. The American College of Obstetricians and Gynecologists and NICE over in the UK echoed that sentiment.
Because they were emphasizing the glaring lack of long-term randomized data.
Exactly.
But if we look at the counter-evidence in our stack of sources, the FDA's stance seems almost contradictory to the recent clinical trials.
The clinical data certainly paints a far more complex picture than that FDA warning suggests.
Like the VILV trial, right?
Yes. The Velvet trial directly compared laser therapy to vaginal estrogen. And then there's the pivotal 2020 double-blind, sham-controlled trial by Ruan Fu.
A sham-controlled trial meaning they faked the laser for some patients.
Right. In a sham-controlled trial, the control group undergoes the exact same physical procedure.
So the probe is inserted.
The probe is inserted, the sounds are played, but the laser energy isn't actually emitted.
Oh, wow. So that isolates the placebo effect perfectly.
It does. And these studies consistently demonstrated that ablative lasers are highly efficacious for alleviating GSM symptoms in the short term.
So how do we reconcile that rigorous sham-controlled success with the FDA's claims of severe burns and scarring?
By looking at the FDA's own adverse event tracking system, the MIUE database.
Okay, what does the database show?
Well, a comprehensive review of that database revealed only about 45 reported adverse events related to these lasers.
Wait, 45 events? Out of how many procedures?
Out of thousands upon thousands of procedures performed globally.
Are you kidding? That's it?
That's it. From a purely statistical standpoint, the adverse event rate is remarkably low.
So why did the FDA freak out?
Many clinical researchers argue that the FDA fundamentally mischaracterized the risk profile.
By doing what?
By lumping legitimate, highly regulated medical interventions for debilitating post-cancer GSM in with elective, medically unnecessary vaginal rejuvenation procedures.
Procedures marketed by cosmetic med spas.
Exactly.
That distinction is wild. I mean, treating a severe anatomical post-radiation complication is fundamentally different from a cosmetic spa treatment.
Completely different.
Marketing a Class II medical device for rejuvenation feels incredibly irresponsible.
It does. And this raises an important question. How does the medical community protect vulnerable patients from profit-driven cosmetic trends while still providing access to a technology that shows genuine, evidence-based promise for pain relief?
Right. Because the aggressive marketing and the lack of standardized oncological training in these med spas have just heavily clouded the clinical utility of the lasers.
Absolutely clouded it.
Well, here's where it gets really interesting. And this brings us to the absolute core focus of today's analysis.
Okay.
The big question. We know radiation wrecks the tissue's blood supply. We know hormones are off the table for some survivors.
Right.
So a patient suffering from severe GSM reads about the Velvet trial, sees a non-hormonal laser clinic down the street, and decides to book an appointment.
A very common scenario.
Should oncology clearance be obtained before that laser ever touches their tissue?
It is absolutely non-negotiable. Oncology clearance must be obtained.
Emphatic.
An emphatic yes. In fact, across multiple definitive clinical guidelines, a history of pelvic radiation is listed as an absolute contraindication for vaginal ablative laser therapy.
The irony is just staggering.
It really is.
The exact demographic demographic of patients who need non-hormonal relief the most.
Mhm.
These cancer survivors with intense GSM are the very people strictly prohibited from getting this treatment.
Yes.
But why? If the laser just heats the tissue to 40 degrees to stimulate collagen, why is previous radiation an absolute deal breaker?
It all comes back to your scorched building analogy.
Okay, the wrecked plumbing.
Exactly. And the physiological reality of irradiated tissue. Irradiated tissue is profoundly fibrotic. And crucially, its vascular network, the blood supply, has been permanently compromised.
Because the radiation fried it.
Right. And elladative lasers rely entirely on a healthy body's ability to mount a robust wound healing response.
Oh, but if the plumbing is wrecked, the repair materials literally can't get to the site.
That is exactly the biological problem.
Wow.
If you apply a thermal burn to irradiated tissue that lacks the blood flow to bring in macrophages and fibroblasts, you do not get neocollagenesis.
You don't get the new collagen.
No. The tissue simply cannot heal. You are just inflicting a burn that will remain open.
Oh my God.
The risks escalate immediately to catastrophic complications.
Like what?
Severe tissue necrosis, worsening fibrosis, and fistulas.
Fistulas.
Yes, which are devastating abnormal connections that form between the vagina and the bladder or rectum.
That is horrifying.
It is. So the FDA's warning about severe burns actually is highly relevant, but specifically for this contraindicated population.
So applying an ablative laser to radiation-damaged tissue isn't just ineffective. It is actively, profoundly dangerous.
It is a recipe for irreversible anatomical damage.
Wow.
Furthermore, active cancer treatment is also a strict contraindication. The medical guidelines are unequivocal.
Okay.
Any woman with a confirmed diagnosis, a suspected diagnosis, or a history of cancer requires a multidisciplinary team, or MDT, to review her pair before any energy-based device is considered.
A multidisciplinary team, meaning the gynecologist cannot just act in the silo.
No, they cannot. They need the oncologist and the radiologist at the table.
Because they don't have the whole picture.
Exactly. The oncologist is the only practitioner who holds the exact dosimetry map.
The radiation map.
Yes. They know the precise gray units delivered to every millimeter of the pelvic floor. They are the only ones qualified to evaluate whether a specific patient's tissue retains enough vascular integrity to survive a thermal injury.
So oncology clearance is not an administrative hurdle.
No.
It is a vital, non-negotiable safety checkpoint designed to prevent life-altering injuries.
That's exactly right.
But if you're sitting in the oncologist's office and they look at your dosimetry map and tell you the ablative laser will cause necrosis, what are your options?
It feels like a dead end.
Right. You can't use hormones. You can't use the ablative laser. Are there alternatives that don't rely on thermal injury?
Yes, thankfully. The MDT has other tools.
Like what?
They might recommend non-ablative lasers.
Non-ablative, okay.
Specifically near-infrared lasers that utilize photobiomodulation.
That sounds incredibly sci-fi. How does that work?
Well, instead of relying on heat and tissue destruction, these lasers stimulate the mitochondria directly at a cellular level.
Oh, so no burning at all.
None. They promote blood flow and relax muscle tension, which presents a vastly safer profile for irradiated tissue.
That makes a lot of sense.
They might also deploy highly specialized pelvic floor physiotherapy to manually address the stenosis.
Just physically working the tissue.
Exactly. Or prescribe targeted non-hormonal moisturizers. But the fundamental rule remains.
The oncologist has to make that call.
Yes, based on the cellular reality of your specific tissue.
Wow. We have covered immense ground today.
We really have.
We started by mapping the scorched earth physiological reality of what curative radiotherapy actually does to pelvic tissue.
It's not a clean fix.
No. Then we navigated the complex hormone tightrope, looking at the mechanical brilliance of how localized vaginal estrogen quantifies the tissue to safely bypass systemic risks for many survivors.
We also dissected the controversial rise of energy-based devices.
Right, separating the rigorous data of sham-controlled trials from the aggressive, profit-driven Wild West of cosmetic med spa marketing.
And we anchored all of this on the definitive, life-saving absolute necessity of oncology clearance.
Because, as you said, a thermal burn on fibrotic irradiated tissue isn't a cure, it's a catastrophe.
Truly a catastrophe.
So what does this all mean?
I think it means that surviving the initial cancer is genuinely just chapter 1.
Yeah. The rest of the book is about the grueling work of reclaiming your quality of life, and that requires highly coordinated, customized science, not a quick cosmetic fix.
It also forces us to confront a significant gap in how we approach oncology as a whole.
What do you mean by that?
Well, our medical technology has advanced enough to cure previously terminal pelvic and breast cancers.
We can reliably save the building, to use our analogy.
Right, we saved the building. But the sheer volume of patients suffering from these devastating secondary symptoms highlights a systemic failure to look beyond the initial survival metric.
Oh, I see. You're talking about shifting the research focus from just eradicating the tumor to actually preventing the collateral damage from happening in the first place.
Precisely. The next great frontier in oncology isn't just higher control rates.
It's finding a way to biologically engineer the treatments themselves to preserve sexual health and tissue integrity from day one.
We need the medical system to equally fund and prioritize the research to cure the cures.
Cure the cures.
Imagine a paradigm where preventing that scorched earth is integrated into the primary treatment plan, rather than treating the permanent anatomical fallout as a decades-long afterthought relegated to separate clinics.
Curing the cures. Moving from a system that accepts the jagged, scorched aftermath of survival to engineering a medical reality that truly leaves the patient whole from the inside out.
Exactly.
It reframes the entire concept of what a successful cancer treatment should look like, something for you to think about. Until next time.